Alright guys, this pressure volume loop may seem intense at first, but we're going to dominate it. It basically just plots left ventricular volume on the x-axis and left ventricular pressure on the y-axis. So let's just go ahead and start here where the mitral valve opens, at the bottom left of the diagram. And so at this point in the diagram, on the x-axis, you see the end systolic volume. This indicates that we have some volume remaining in the chamber after we've completed systolic ejection. So we need to replace the ejection volume. What happens? We open the mitral valve. So the 4 and 5 here, these indicate the rapid and the slow filling period in diastole. There's an arrow pointing to an area just after the mitral valve opening, indicating that we could potentially hear an S3 here. So let's play that real quick. Okay, here we go. Alright, you guys hear that? It's rather quick, but S3 is kind of a confusing heart sound because it can occur in a normal person and it can also indicate an underlying pathology such as a dilated ventricle. Now the best theory so far is why an S3 occurs is that when the ventricular wall hits a limit of expansion from the rapid filling period in diastole, it makes this noise. Now as we continue to travel along this way with the black arrow, we see another arrow pointing to S4. Now we said that S3 could occur in the early rapid diastolic filling period. So when do you think this S4 can be heard? It occurs in the late or reduced diastolic filling period. And S4 occurs when the left atrium squeezes down to push that last bit of blood into a non-compliant left ventricle. So the incoming blood creates very turbulent flow because the ventricle is not going to expand. And the turbulent flow of blood creates an audible sound that you can hear over the apex. What does it sound like? Well, let's listen. Alright guys, let's keep going. Next up, when we finally reach the corner, we hit S1. We also have an arrow labeling mitral valve closure. This makes sense because the closure of the mitral and tricuspid valve makes the S1 heart sound at the end of the diastolic filling period and at the onset of systole. So let's keep on going. Next, we start moving vertically in this direction. This is because there's a change in pressure but no change in volume, because both the aortic and the mitral valves are closed. So this phase 1 here represents left ventricular contraction against a closed mitral and closed aortic valve. We call this isovolumetric contraction because iso means same. There is no change in volume. That's because the back door, the mitral valve, and the front door, the aortic valve, are closed. But when pressure rises to a high enough point, the aortic valve is going to swing open. And we start moving to the left on the diagram because we're decreasing left ventricular volume because volume is going into the aorta. So the ventricle is going to contract and increase pressure all the way up until ventricular relaxation occurs. This is where the curve peaks and kind of starts to drop off. When the ventricle relaxes enough, the pressure in the aorta will now be greater than in the ventricle. What's going to happen? Well, now we get closure of the aortic valve, and this is part of our dub or S2 heart sound. The last step we have is the opposite of isovolumetric contraction. This is isovolumetric relaxation, and this is represented here on number 3 of your diagram. So this ventricular relaxation occurs with the aortic and mitral valve closed. Eventually, we're going to have enough relaxation where the left ventricular pressure is going to fall below that of the left atrial pressure. And what's going to happen again? Well, we start the whole thing over with the mitral valve opening. What are the other loops on this diagram about? Well, the lime green curve represents an increase in preload. The loop expands more to the right because the end diastolic volume is greater in the left ventricle. Notice how we're shifting on the x-axis. Preload and end diastolic volume are the same thing. So an increase in end diastolic volume will stretch the sarcomeres. And by Starling's law, this will cause an increase in the stroke volume, but it will not change the end systolic volume. Notice how it's in the same place on this side because all we did was increase more blood into the chamber. We haven't changed the ability of the chamber to contract. We've just increased the ability to rebound for how much volume we put in there. Now this red-orange curve here represents an increase in contractility. Remember that contractility is the intrinsic ability of the muscle to compress the blood in the left ventricle. So the closure of the aortic valve occurs at a lower end systolic volume, Notice how we have shifted out here. This is because the ventricle is better at ejecting blood due to increased contractility. Now, what about the last situation in which we have an increase in the afterload? We would see this situation in something like hypertension. The increased aortic pressure will require your left ventricle to contract harder to reach the pressure necessary all the way up here to swing open the aortic valve. Notice how the Y value is much higher compared to the other ones. We have to reach a higher ventricular pressure before we can open the aortic valve. So if you have to push much harder to eject volume from the left ventricle, guess what's going to happen to your stroke volume? Well, it's going to drop. It's going to get smaller, right? Notice how this is also representative on our diagram. This is our stroke volume here. It is decreased. So our stroke volume drops. This means that more blood remains in the ventricle at the end of systole. This is represented by the shift on the x-axis of our diagram. Alright guys.
The next diagram shows us how you're expected to integrate information about what's going on in the atria, ventricles, jugular vein, in addition to heart sounds and the electrocardiogram. You'll be expected to be able to put all of this information together when you're actually evaluating a real patient or when you're trying to answer a question on your Step 1 exam. We're going to roll through this diagram starting with atrial systole. So even if this diagram didn't say atrial systole here at the top, we can see the atrial pressure, represented by the dotted line here, shows a slight increase, which makes sense because the atria are going to be contracting and compressing the blood within them to push them into the respective ventricles. The depolarization necessary to make the atria contract is shown as the P wave here. Now how does this correlate to the A wave on the jugular venous pulse tracing? Remember that there is no valve in between the right atrium, superior vena cava, and the jugular veins. So any pressure changes in the right atrium are going to be reflected all the way back to the jugular veins. Anytime your atria depolarize and contract, there's going to be an increase in pressure that is transmitted all the way back to the superior vena cava and then the jugular veins. So this is represented by the A wave. I like to think about A as atrial contraction, which you can see in the jugular venous pulse tracing. In the case of atrial fibrillation, we lose the A wave. Why? Well, because there's no unified contraction because atrial myocytes are fibrillating and contracting out of synchronization. So the A wave in AFib is gone. Now with respect to heart sounds, so if the left atrium is contracting to push blood into the left ventricle, but the left ventricle is non-compliant, you can potentially hear an S4 heart sound. Why? Well, a non-compliant ventricle requires the left atrium to create a very high pressure in order to push blood into the left ventricular chamber. Remember, a poorly compliant ventricle means that for a change in volume, change in pressure is greater. So you have to get the pressure higher in the left atrium. This may or may not be abnormal, so if you hear an S4, you should probably order an EKG and an echocardiogram to see what's going on. You want to see what the left ventricular wall looks like. Now let's take the next step and examine what is going on during isovolumetric contraction and rapid ejection. The QRS complex down here represents ventricular depolarization, right? So the result of this QRS depolarization is ventricular contraction and an increase in left ventricular pressure. You can see here the left ventricular pressure tracing is going up. Now when the pressure in the left ventricle is going to be finally greater than pressure in the left atrium, the increase in pressure is going to do what? It's going to slam the mitral valve shut. This mitral valve closure is part of the S1 heart sound. Now the ventricle continues to contract until the pressure in the left ventricle is eventually going to exceed the pressure in the aorta. And at this point, the aortic valve is going to open. We can confirm this by also noting how the left ventricular volume is going to suddenly just drop, right? That's because we have ejection. This is the rapid ejection phase. What would you see in the JVP tracing at this point? All right, the C wave. Notice how right before the C wave occurs, pressure was a little bit lower. The pressure tracing was dropping due to atrial relaxation, but right ventricular systole interrupts it by creating the C wave. Now, before the pressure is high enough to open the pulmonic valve, right ventricular contraction compresses the blood in the chamber, which makes the tricuspid valve, which is right here, it makes it just kind of bulge up into the right atrium. So this ballooning of not only the tricuspid valve leaflets, but also the fibrotic annulus up into the right atrium creates this C wave. So if it goes up, what has to happen? The tricuspid valve leaflets now have to come back down. So when the tricuspid valve returns from bulging into the right atrium, the leaflets return to normal position, and this leads to the resuming of dropping the jugular venous pulse waveform, which resumes with the X descent. The X descent occurs as a result of more atrial relaxation and continued right ventricular contraction in the latter half or the second half of rapid ejection. So both of these movements result in inferior movement of the tricuspid valve and its annulus or fibrous ring in the latter half of the rapid systolic ejection. So again, inferior movement of the valves, the annulus that the valves connect to create a little bit of a negative pressure, and this negative pressure is reflected in the right atrial pressure tracing that is transmitted back to the jugular veins. So now we move on to the next step. Now we're going to examine reduced ejection and isovolumetric relaxation. Eventually the ventricles start to reduce in contraction and they start to relax. So the pressure in the aorta will now eventually be greater than the left ventricular pressure. What does this do? This leads to the closure of the aortic valve due to a pressure gradient. What is this Dicrotic notch? That's not actually that important, but it's on the diagram and you gotta understand it because someone's gonna ask you about it one day or you're gonna feel uncomfortable for not knowing it. So dicrotic means 2 beats. So this little initial drop, then rise in the aortic pressure reading, it looks like a V. That is the dicrotic notch. It's created from the regurgitation of a tiny bit of blood back into the left ventricle as the aortic valve leaflets are coming together. So here are the aortic valve leaflets, and here's that little regurgitant flow. This regurgitation will actually have an effect of kind of sucking the valves backwards into the left ventricle as the aortic valve leaflets are coming together. So again, this regurgitant blood flow pulls the aortic valve leaflets backwards towards the left ventricle, and then the leaflets will recoil back towards the aorta as the coronary arteries are being perfused. Now this whole process creates this dicrotic notch. It's not that high yield because it has really minimal clinical application. Now the S2 heart sound occurs here because it is the closure of the aortic and pulmonary valves. The V wave in the JVP tracing corresponds to the filling of the right atrium against a closed tricuspid valve. So as we accumulate blood in the right atrium, the increase in blood leads to increase in pressure, right? This is also sent backwards in the superior vena cava and the jugular veins. The T wave in our ECG tells us that the ventricles are repolarizing. It seems like it occurs early because it does. The electrical changes are one step ahead of the contractile forces that are changing the volume and pressure tracings. Now we have diastole, noted as rapid and reduced ventricular filling. You can see that the left atrial and left ventricular pressure tracings are stacked on top of each other. This is because there is no mitral valve separating the 2 chambers. The valve leaflets are not touching each other. The left atrium and the left ventricle are wide open to communicate with each other. So you can basically consider the left atrium and the left ventricle as just one chamber because there's no mitral valve leaflets coapting to separate them. You can also consider the left atrial pressure to be equal to the left ventricular pressure at this moment in time. So can you remember what an S3 heart sound is caused by? This is caused by blood rushing into the left ventricle and the ventricle hitting its limit of expansion. This can occur in young individuals that exercise a lot or in pregnant females. Well, all females would be the ones that would be pregnant. So consider the population described in the vignette if you are being asked a question on this. Now, the last thing we need to consider is the Y descent. What does the Y descent represent? Well, we just said that the V wave was right atrial filling and increase in pressure. So as the pressure in the right atrium increases due to more blood volume, we reach a point when the right atrial pressure is greater than the right ventricular pressure. This will cause the tricuspid valve to open. So blood is now going to be draining from the jugular veins into the superior vena cava, into the right atrium, into the right ventricle. So this flow of blood out of the jugular veins is the Y descent because now there's less blood to create that pressure tracing. Both atrioventricular valves are wide open during this rapid ventricular period.